Hello everyone, welcome back to Health Economics. So starting this week, we are going to switch our focus away from the demand side of the healthcare markets to the supply side. So in chapter 5, we are going to start talking about the labor markets for physicians, to talk about the position that supplies the healthcare services. There are several things that we would like to cover in this chapter. So first of all, we would like to talk about the trainings of physicians, and then we would like to talk about the wage, and more importantly, in this chapter, we would like to discover the barrier to entry for these positions in the markets. And later, we would like to talk about the nature of the jobs for physicians and also some of the expectations of physicians in the markets. And of course, there are some discriminations of these physicians that we would like to also discuss in the later chapters. So training for physicians is a very important topic because this is basically acting kind of like a barrier to entry. It's not everyone who wants to be a doctor or maybe a physician. They can easily enter to the markets to provide the service. In fact, most of the physicians out there, they have to go through a very, very long times of trainings, residencies, and practice in order to practice their the skills or maybe to provide the service in the markets. So let's start the topics on medical school. Well, if one day you want to become a doctor, well, the medical school basically is the entry level of skills that you need to get through. So the 4 years medical school program usually prepare you to be doctors in the future. Entering to one of these medical schools in the United States is relatively competitive, and also at the same time it's very selective in the worldwide markets. Taking the case in the US, there's about average 50% of the applicants are accepted into at least one of the medical schools. Well, not only it's difficult to get in, but the length of this medical school usually varies across country. So in the case of US and Canada, most of the applicants, they have to first at least get their bachelor degrees before they actually enter to this medical school. So that means the medical school will look at your backgrounds and they expect students to have at least college level of educations before you get into the medical school applications. But in Europe, it's somehow a little bit more relaxed on this entry requirements. Applicants, they can actually go directly from high school. Going to the medical school can be super expensive. Taking the case in the United States, it usually costs from about $140K to $225K for 4 years of programs. But on the other side of the world, European country usually has a very, very generous subsidize on medical trainings. So on average, they might actually spend about 200 to 500 euros a year. So relatively, it's a lot more appealing for people who study in the medical school in European country than in the US and Canada, both time-wise and also financials. Well, other than going to medical school, taking classes, learning the basic knowledge of becoming a physician in the future, well, of course, there are some on-hand trainings. So the periods people spend on the job trainings, it's basically what we call the residencies. So residencies, it's basically a period for students to learn the hand-on experience in the hospitals. This experience are actually very important because this is a real-world experience. It gives the students the real scenarios that could happen in the hospital so that they can actually learn from the realities. Usually new residents actually lacking of this experience. When the new residents arrive at the hospital, obviously the medical error will go up because these new residents will make mistakes at the early stage. And there is a phenomenon that actually explains the jump of this error during certain period in the year. Well, taking the case in the United States, we do have this July effect. Well, why do we call this July effect? It's because when people start graduating from the medical school and not actually graduating, but they start finishing their classes in the spring semester, and they get into one of these residencies on-job training positions in July. Well, obviously with this, the flush of this huge number of new students or residents into the positions, it increases the error in the hospitals dramatically. There's another term in the UK, we call this a August killing seasons. So the mortality rates in the hospital actually increase dramatically during the month of August. Well, again, most people believe that it's because of this new entries of the residents. So, physicians are amongst the longest working professionals. Well, one doctor workday can actually last more than 24 hours. Well, there are several duties that they have to do, such as they have to treat the patients, they have to conduct the operations, or there are basically just uncountable forms that they have to complete. So think about the case of surgeons. So a single operations of surgery can actually last as long as 10 straight hours. So it's not surprising. The physicians actually frequently clock more than 60 hours in a week. And some of the on-call residents can actually work up to 30 consecutive hours. And with this long working hours, obviously, it might have an adverse effect on patients' health. Well, in the year of 2003, the Accreditation Council for Graduate Medical Educations, the ACGME, actually implement these limitations on number of works that residents in the US are permitted. So in this limitations, doctor in training were not allowed to work in excess of 24 consecutive hours. And also at the same time, they can no longer work more than 80 hours a week. Well, but the result from this policy actually doesn't really has any effect on patient mortalities. So after the change in 2003, several studies has showing results that for residents to work shorter hour, it has no effect on patients' mortality rates in the hospitals. And in fact, what happens in some of the study actually suggesting many of these residents practicing in the hospital, they are actually usually still working over 80 hours a week, but they are just not reporting it. So what's the problem for working this long hour? Well, obviously there is a trade-off. So for residents or maybe physicians to work longer hour, obviously it will impact the physician's cognitive ability, so that they might actually has a higher chance to make mistakes or error during the patient state. Working shorter work hour, however, it has another trade-offs. So that means physicians will not stay in the hospital as long as they were supposed to before the regulation change. So it requires the physicians to have more hands off to their colleagues or other physicians in the hospital. Well, when this information is passing on to another person, obviously the chance that the crucial information will be mishandled will be higher. So a fewer hands-off between different positions might actually minimize the chance of having this crucial information to be mishandled in the or during the patient states. So let's think of some empirical questions which effects will dominate. So there is a study done by Landrugens in 2004. The study actually conducted a randomized experiment at the Brigham and Women's Intensive Care Units, the ICU, at Harvard. So in this study, basically, we divided the physicians into two groups. So one is the traditional 80 hours per work or 80 hours per week work physicians. And also we have another group which is 60 hours per week, which we call the short work week. So we are basically trying to compare some of the medical results between the two groups in the hospitals. So the result actually suggests that the interns on the traditional schedule commit about 35.9% more serious medical error than the interns on the limited schedules. And also the difference include the 20.8%, about 21% more medications error, and 5.6 times as many diagnostic error. So patients' outcomes, however, do not diverge significantly between the two groups because the senior physicians actually intercept most of the serious errors in this case. Well, this result actually highlights a very important policy trade-off. So residencies is designed to be a safe place for new doctors to gain experience, to learn, to make error without harming the patients. This unintended consequences of work hour limits might actually slow down the learning of residencies so that they will get less supervised practice before they end their residencies. However, no study has examined this trade-off explicitly. Right? It might be the case that the work hour restrictions actually reduce error by residents at the expense of increasing error by the recent graduates of residencies program. So in general, we believe shorter hour is good for making less error, but we don't know where that come from. Is it just because they are working longer time so that they don't have the ability to stay up? But we do note there is one very important trade-off. The shorter the hours or shorter the weeks the new physicians or the residents work, obviously there will be less of the experience they can gain in the reality by having this supervised practice. So talking about all this trainings of physicians, well, now we would like to take a look at the returns for going to the medical trainings. So why is it a attractive positions for most people still? If assuming people has to work that long hour, right? So why would people be attracted to these positions? So the returns to medical training is not like most of the occupations we expect to have in from our college. Obviously, the investments that we put into medical school, it's a lot more than the regular bachelor degrees that we usually earn from college. So going through medical school, obviously it requires a direct financial cost, money to get into those very expensive medical school. And also at the same time, it's involved with a very huge time cost, which is an opportunity cost. So the return to medical trainings are very backloaded. So just like the diagram here illustrates, at the early stage of time, obviously we are still investing a lot of the money going to school. Well, after we're done with the medical school, now we get into the residency programs, and we have to invest a lot of our time, very long work hours, but getting very, very low pay for those intern positions. Once we finish the trainings or the residency program, well, now finally we can the complete physicians can go out there in the markets to start practicing. So the time, obviously, getting those trainings and learning done, it's a lot more longer comparing to a regular occupations that we can find in the job markets. So those who choose to become a physician, obviously they are very, very patient, and they value the future returns a lot comparing to what we can earn right now. So what makes up the decisions whether we want to be a doctors or we want to be maybe just some accountants in the futures? So obviously, we can study this decision by looking at what we call the present values. So consider we have this one college graduate trying to pick a career in the future, and the only thing he cares about is the income. So this college graduate should always pick the career that maximizes the net present values of his income. So net present value basically capture how valuable a lifetime stream of income is to an individual today. Basically, we say, well, there is a lifetime earning income for this individuals, and the individual actually think about the income nowadays has a higher value than the future. So that means we have to discount the future incomes and add them up in order to get this net present values. So basically, this is a discounted sum of all future incomes for these individuals. Well, we have this term here called the discount factor, and we call this a delta. So this discount factor, it's actually a measure of how much less of an individual value the future income over the present income. So comparing the future incomes earned, let's say 1 year later, the $100 in 1 year later, comparing to the $100 that we earn now, well, obviously, the $100 worth less to us in the future, because we think that, well, first of all, money devalue over time, and not only just that, something that we can earn in the future does not immediately provide us with the enjoyments for buying the goods and services. It's something that we can get in the future, but not now. So somehow what we have in today, we value higher comparing to what we'll have the same thing, let's say 1 year later. So it will be discounted. Whatever incomes that we earn in the future will be discounted by this delta here. So this delta or discount factor always fall between 0 to 1. If it's small, that means the individual is actually impatient. And if this delta or discount factor is large, that means the patient is actually, or this college graduate, it's kind of patient. They want to actually goes into a job positions that can provide, or maybe to have a higher chance to earn higher level income in the future. So those with higher delta will have a higher net present values from being a physicians. And those with low delta, well, usually will have a low net present values. So that means, well, he values something happens right now, today, it's more important. And something that they earn in the future, it's less important, so that they will pick the job that they don't have to spend too much time. They can immediately get the income from the jobs. Well, by the same logic here, we can also rewrite the discount factor, delta here, equals to 1 over 1 plus R. So this term R actually represents the discount rates. So how much we actually discount our future income. So this is basically acting like a market interest rates. So it's basically the income that we forego by not having this money or wealth put it into a saving account. Right? So you can actually think about the discount factor. It's actually indifference between saving for tomorrow or maybe spending today. So we can actually have the income now versus we can actually have the incomes in the future. And how much it will be discounted? Well, basically is discounted by the interest rates that we can put the money into the saving accounts to earn that extra income in the future. So for example, if we get a delta that is equal to 0.9, so this delta here represents if we are going to earn $100 today versus we can actually earn the $100 in the next period, let's say next year. Well, we value the $100 as $100 values today. Right? So we can buy $100 worth of goods and services today. However, when we are getting the $100 in the future, which is next year, we think that that $100, the same $100, only worth $90 to us. It's only 90% of the total value that we earn today. Because the fact is, the money can devaluate, and also what we can buy today might not be the same as what we can buy in the future. And also, well, you can actually use this number 0.9 to figure out the market interest rates are, or the discount rates, which is equal to 0.11. So what does it mean? So it basically means if we are going to have this $100 today, if we put it into saving for 1 year, we earn 11% of interest. Well, 1 year later, we should get $111. So that $111 that we earn 1 year later by putting the money into a saving account, worth the values of $100 as of today. So basically the idea is a very patient graduates have a higher discount factors, delta, and lower discount rate, R. So this person with patience will actually discount the future income less. So he will value the future incomes a little bit higher comparing to other people. So this guy will think that it's worthwhile to put into the time and efforts and money to invest for the future income instead of getting out of college and start working for accounting jobs or maybe marketing jobs or maybe other positions. So learning the discount rate actually help us to figure out whether the person is patient or impatient, and also the patient college graduates obviously will pick a career path that lead them to a higher future returns in the career, and a more impatient college graduate will pick a job that actually provide them a more immediate income with less investments at the current state. But they don't actually consider the future income will be that important because they discounted so much of it. Well, there is another important terms that we would like to use to compare the two career choice for an individual. Let's suppose there are two career choices here, P and C. Let's say P represents physicians and C represents accounting. And there are two income paths, which is IP and IC here. So it's the total income that can be earned by these two careers here. There is one very special discount rate, or maybe we call this a internal rate of return, R star here. This is a rate or discount rate that actually equalize the net present values of both careers. So in this case, we are basically assuming there might be one internal rate of return or discount rates where the individual is indifferent comparing two career paths. So this interest rate or this discount rate represents if this person has this rate of returns for the career path, this guy will be indifferent for choosing either to become a physician or accountant. So how are we going to calculate the internal rate of return? It's by the equations here. And obviously, we are not too in depth to talk about these equations. This is not the ultimate goal, but we are just saying, well, this internal rate of return actually provide us to believe this individual will be indifferent comparing the career path from physicians or becoming a accountant. So by comparing the internal rate of returns to the individual discount rates, obviously we can actually get some conclusions. If the internal rate of return is actually higher than the actual individual discount rates, so let's say the internal rate of return for this person to choose between physicians and accountant is 13%, and the discount rate, the actual discount rate for this individual student is actually 10%. So this student actually will make a investment because the fact is he discounts the future income less than this internal rate of return. So the future return actually worth the wait for this individual. However, if the internal rate of returns, this R star here, it's lower than the actual individual discount rates, well then this person should not make the investments because the future returns are not worth the wait for this person to invest so much because, well, the future income does not worth as much as he was thinking. So there is a extensive study in calculating the internal rate of return of a career in medicines. The study is actually suggesting the internal rate of return in medicine, it's falling between about 11% to 14%. They're significantly higher than the market interest rate. Also, it's true for some of the other high-skilled professionals, such as dentists and lawyers. The internal rate of return is even higher for some medical specialists, like the neurosurgeons or other highly skilled or specialized medications physicians. The fact that the IRR has stayed high in curious, it suggests that being a physician is highly lucrative. So why this high returns in the future does not attract more physicians? Because when there are more people entering to the job markets to become as physicians, obviously it will decrease the rate of returns because the wages will be driving down by the entries of new physicians. So the internal rate of return is relatively high for some specialized physicians out there, and there are a few possible explanations to it. Well, number one, maybe the specialists actually work more because they can hardly be replaced in the hospitals. So usually they have to work longer hours. Or maybe it's because those specialists actually train longer. So they have much more intensive trainings to specialize their skills. So that's why they get paid more. Or maybe for this specialist, they actually retire earlier. So they have a shorter times to earn the lifetime spans income. So that's why they actually has a higher pay comparing to non-specialists. Or maybe the specialists are more highly skilled. So with this high skilled at the job markets, obviously they might actually earn a higher level of salary comparing to the non-specialist physicians. However, the difference in working hour, trainings, requirements, career length, and abilities in some of the study can only explain half of the salary premium for medical specialists. So in the study of Bhattacharya 2005, obviously the differences cannot be explained by all this factor here. So one of the leftover explanation is there is a significant barrier to entry. So it's not easy to get into those specialist or specialized positions. That's why the salary or maybe the supply of these positions is very limited, which drive up the wages or maybe income for this specialist income. So in this sections here, we are going to study the barrier to entry for this specialized physicians and see how it explains the wage differences. So in the 19th century, becoming a doctor, it's relatively simple. So anyone can do it. There's no regulation about trainings. So obviously, whoever interested to become a doctor in the 19th century, obviously they can easily enter to the job markets and have this skill trainings and to become a doctor. After this 1847, the American Medical Associations has formed to actually put into prerequisites for medical school. Obviously, the entry of doctor has been limited because now you have to at least comply with certain prerequisites in order to get into the medical school. And also the length of medical school becomes longer comparing to the previous. Now everyone has to at least complete 4 years of medical school, become a specialist, or maybe in order to move on to enter the residency practice. And most important, to become a doctor to practice in the markets, you have to now earn a license to practice. So it's not anyone who complete the trainings, they will be able to practice in the markets. You have to actually get a license to do it. Well, 1910's Flexon report actually helped shut down the low-quality medical school. And in this case, obviously, it reduces the medical schools or numbers of medical school in the country, which also further limits the entry of doctors in the markets. Well, by all this, the result is there have been less medical school available for people to trying to get their doctor degree. And at the same time, we are trying to all this policy actually limited the medical students for getting into the medical school to get their doctor degree. So other than these uniform sets of requirements for the MD degree, obviously there are other types of barrier to entry for becoming a physician in the US, such as we talked about the caps on medical school class size. With these restrictions, during the year of 2006 and 2010, only half of all applicants that apply for medical school in the United States were admitted. So it significantly reduced the number of physicians or possible qualifying individuals to become a doctors during that time span. Well, not only domestically we are being restricted, but in the international sense, we also seeing people who qualified to become a doctors overseas has a very, very hard time to enter to the American physicians labor markets. So in order to work in the US, of course, passing all this examination is required. So doctors from overseas, if he wants to practice in the US, obviously they have to actually go through a very, very long application process, such as they have to first go through a limited number of H-1B visa. So they have to apply for this visa in order to work in the United States. But at the same time, they have to, or they must pass all the same licensing tests that required by the American medical graduates. So comparing all these examinations, residency programs, and applying for the H-1B visa, it will become a very, very long process for doctors from overseas to enter to the job markets in the US. There are some other choices out there to replace physicians, such as nowadays we have the nurses to become a patient advisors, or maybe physician's assistant to help patients to seek for alternatives advices. However, this practice nurses and also physician's assistant, it's limited in some of the job descriptions, such as nurses are not allowed to prescribe medications. And also, physician's assistant, they cannot conduct a major surgeries. So that means there are something that, again, still restricted on these alternatives for physicians. There are other types of alternative medicines that the patients or maybe people can seek in the market. However, every single one of them still it's limited in the ability to practice in the markets. That's why for most of the physicians' positions out there, we still see a very, very limited entries every year in the markets. So in general, because of the barrier to entry, the supply of healthcare provider is still very, very limited in the markets. So with this high level of barrier to entry, what are we actually getting out from this healthcare market? Well, from our principal microeconomics, obviously with the barrier to entry, it will create a much higher price the consumer have to pay for the service in the market. So comparing to the perfect competitive market's price, well, now consumers will have to pay more. So the physicians in this case it's basically earning what we call the monopoly rents. The wages will definitely be above the comparative price, and they will be earning much higher levels of income comparing to other positions out there. Well, by paying so much, well, we're actually getting something in return. Because of the barrier to entry, well, we now actually have this high quality of physician service. So all these physicians are basically at least meeting these high qualifications in order to get past of these exams and medical schools and residencies programs. So in this case, yes, the consumer actually pay more, but then as a social perspective, well, now we actually don't need to spend that much time in the market to sit for the qualified physicians, because, well, they are all very highly qualified to provide service in this market. Comparing to if this is a unregulated market, obviously now consumer has to actually spend time when they're sick. They have to spend time to look for a better physicians out there in the markets. So this barrier to entry actually might improve the total welfare after all. So now we are going to move on to the next sections to talk about the physician's agents. So let's talk about the role of a physician, or maybe a doctor. So one of the primary things about patient paying a doctor is for information. So doctor basically they are trained to interpret subtle signs and make treatments recommendations based on those informations. Obviously, to become a perfect agent in the market, well, the doctors it's expected to make a correct recommendations to the patients, only that it's best for the patient's well-being, but not based on their own financial status or reputations. But the problem is, are doctors always a perfect agents in the markets for their patients? Well, I would say one very important factor is, does the patients actually have full information when they actually seeking their doctors? Does the patient actually can tell whether the treatments assigned by the doctors it's a correct recommendations, or maybe the patient actually has to heavily depends on the recommendations by the doctors? I would say in most cases, patients are not having the perfect information in the markets. So this uninformed patients basically it's at the mercies of his doctors. This information asymmetries actually between doctors and patients create an opportunity for doctors to actually prescribe more services than what the patients actually want or needs. One of the most popular phenomenons that health economists study is what we call the physicians-induced demand. This is a problem created in the markets because of the asymmetrical information between doctors and patients. Patients cannot assess whether the extra tests or procedures ordered by the doctor is necessary. And in most cases, when we go see the doctor, we heavily depends on the recommendations because, well, we just don't have the knowledge, or maybe we don't have the full information about our conditions in order to assess whether the doctor is doing the right thing or not. This physicians-induced demand is basically the extra demand created for medical goods and services that is assigned by physicians or doctors other than the patient's objectives, but according to their personal incentives, such as the financial gains on their own. There are several evidence has been found that doctors actually behave in different ways if a different reimbursement system it's assigned in the markets. So in the study of Hickson, 1987, the study actually randomly assigned a group of pediatric residents to be either paid by a fixed salary or paid by according to the numbers of service assigned for the patients. Well, if both groups of residents actually behaving as a good agent, or they are actually taking the first priority for the patient's health, well, obviously they will assign a treatment pattern that will be statistically the same. However, we actually finding evidence that the free-for-service physicians not only schedule more visits per patient than the salary-based physicians did. They also schedule more visits than they were recommended by the American Academies of Pediatrics. So that means not only they behave differently comparing to the salary-based physicians, which more patient does not actually increase the income, but because the fact that they can get even higher level of income, they actually go even further than what is recommended by the regulations or policies suggested. Well, other than the physicians-induced demand, there is another theory also explain why doctors or physicians, they will usually deviate from the optimal medical practice or to assign more than what the patient needs in the market. Well, this theory is called defensive medicine. So the defensive medicine actually is when the physicians or doctor deviates from the optimal medical practice in order to reduce the risk of conflict with the patients, especially in the forms of malpractice lawsuits. So obviously, the doctors, they from time to time, they would like to avoid any possibility that will put the patients into any catastrophic situations or conditions. So they don't want anything bad happens to the patients. Sometimes they may be so fearful of these outcomes that they will actually prescribe more than what is needed for the patients. So when that happens, obviously the defensive medicines, it's being created for this excess demand for the healthcare services or medical goods. There are evidence found everywhere, not only in the US. Well, the problem for this defensive medicine is that it creates a huge increase of demand for healthcare services, which again drive up the costs for healthcare services and goods. There's a study done by Mellows, 2010, The study estimates the medical liability system in the US, which costs about 55.6 billion annually. So this is a huge amount of money that could possibly go into the lawsuit case for malpracticing in the US. So therefore, doctors and physicians, they have this great incentive again to prescribe more than what the patient is needed. There are other ways that the doctor can respond to liability risks, like the malpracticing. There is an insurance that it's called liability insurance, which is like a health insurance. It actually smooths the consumption by charging a premium to the doctors and reimbursing those doctors who face a malpractice claims. Of course, the full liability insurance may induce other preferred incentive. However, being over-cautious about care, fully insured doctor may be less diligent in protecting against error, because the risk now it's shouldered entirely by the insured. So that's why the full liability insurance actually might lead to more medical error and more malpractice claims. And that's why nowadays we don't actually see a lot of full liability insurance that cover the malpractice in the healthcare markets. So we have take a look at two theories that explains under the asymmetrical information markets, patients will be have a chance to be over-prescribed with the medical goods and medical services. However, it's not necessary every time we will get the inappropriate treatments or prescriptions from the doctors because of the asymmetrical information. Indeed, sometimes we could get the inappropriate treatment because we are being discriminated in the markets. So discrimination by physicians might take a few different forms. Well, some doctors actually prefer not to interact closely with certain race group of patients and cannot diagnostic them or advise them effectively. Well, in the case of taste-based discriminations, they are less willing to assert themselves to do everything within their power to help this specific racial groups of patients in the market. So basically, we are describing when the doctors or the physicians, they are trying to treat the patients differently based on the taste on preference of their ratios of the patients. There is another type of discrimination. It's what we call the statistical based discrimination. So this is basically a differential medical treatment for certain groups of patients based on the stereotypes of their biological or behavioral tendencies. So for example, it could be the case a doctor might treat a certain racial group of patients differently because of the biological differences between races, or because the doctor basically just believe that this group of people are less likely to follow up with medications or other doctors order, or are not good candidates for treatments in the first place. Well, there's a very important distinction between efficient or inefficient discriminations. So when we are trying to study the social welfare of the medical markets, we have to actually distinguish whether the patient is being discriminated with benefits or maybe at an even higher cost. So one of the study that illustrates the discriminations in the health care market It's done by Saltman, 1999. So in this study, basically we divided up two groups of hypothetical patients, which is they are actor basically hired by the researcher. One group, they are all blacks. The other group are all whites. So they are basically given the same scripts to read out to the doctor they are going to visit later, and the same backgrounds they told the doctors, and also they have the same hand motions or same gestures when they seeing their doctors. So the only difference that the physicians actually see it's by its ratios. Well, the results in this study is the physicians that were tested in this study were overwhelmingly white males, and they were significantly less likely to recommend black patients with chest pain for the standard treatments. Unlike the white patients, usually the black patients were given less of the standard treatments in this study. So is this a taste-based discriminations or statistical discriminations? Well, obviously, this disparities in treatment is evidence of discriminations. But when we are trying to evaluate what kind of discrimination it is, it really comes down to the point that whether the doctor is given the treatments or the prescriptions based on the race mainly, or is it based on the biological needs for the treatments? Well, there are medical research actually showing that the optimal treatments for hypertension in black patients it's different from the optimal treatments from whites. So in this specific case, it could be the case the doctors or the physicians, they are given different treatments for the black patients because they based it on the biological differences. So in this case, by using the statistical discriminations or maybe discriminating patients by statistical backgrounds, it actually saves lives, or it might actually benefit the black patients specifically in this case. So generally speaking, taste-based discrimination is always inefficient. So patients will not get the optimal service or will not be treated with care or taking good care by the doctors or physicians if the physician actually discriminate the patients based on the ratios. On the other hand, the statistical discrimination might be efficient in the market. So for example, it could be the case that we studied in the previous slides when the doctor actually given the treatments based on the statistical backgrounds or biological backgrounds based on the facts that it's better treatments for a certain group of people, it might actually benefit or increase the level of health for the patients. So to conclude this chapter, we have picked up many informations about the supply side of the medical market. First of all, the physician supply in the United States or maybe around the world, they are highly regulated. Well, it's very difficult to enter the market to supply those services in the markets because of the regulations or policies, the licensings. It leads to a very, very high shortage of doctors in the market. It's very, very hard for the healthcare provider to fill those voids. So in the foreseeable future, still we are facing this shortage of doctors, which leads to a higher price that we have to pay in the markets. The investment return to be a doctor or specializing is very, very high. So that it only makes sense for people who are patients or who has a very low rate of discounts rates or discount factors to get into those industries. So people who usually don't have this patience or maybe has a very, very high level of discount factors for their future incomes, obviously those are the people will not join the physicians markets. We also learned that the physicians are not always the perfect agents for care. Most of the times they overutilizing the care for the patients. Physicians induced demand and defensive medicines explains the reason why the patient usually get more than what they needed. Also, we have discussed about the racial discriminations that help explain why sometimes different racial group is getting different treatments even though they are paying the same price or going to the same physicians or doctors. So this is basically the introductions of supply of the healthcare markets. So this is basically coming from the labor markets of physicians. Later, we are going to discuss a little bit more about the supply side of the healthcare markets related to maybe the hospitals or maybe insurance, which is the next chapter we are going to discover. So I will see you next time.